Hereby I open this academic ceremony in which Maggie Han will defend the academic thesis, Physical Activity and Sleep Monitoring using Wearable Devices in Patients on Hemodialysis. May I invite you to present a summary of your study and the conclusions of your thesis.
Good afternoon. First, I would like to start by welcoming the members of the Corona, my supervisors and co-supervisor, and family and friends. Today, I will be discussing my thesis titled Physical Activity and Sleep Monitoring Using a Wearable Device in Patients on Hemodialysis. Kidney failure with replacement therapy is defined as being on dialysis for at least 90 days or having received a kidney transplant. In 2023, there were 4.59 million cases of kidney failure with replacement therapy globally. The most common modality is hemodialysis. Here on the right, we have a figure depicting the hemodialysis treatment where the blood is pumped away from the patient through the dialyzer where the blood is cleansed with dialysis fluid running counter to blood flow, and then the clean blood is then returned back into the patient. The most common hemodialysis prescription is done in-center 3 times per week. Patients on dialysis experience higher mortality compared to the healthy population. They experience a heavy symptom burden due to an accumulation of uremic toxins, fluid electrolyte imbalance, anemia, bone mineral disorders, and other factors of the kidney failure. Negative symptoms of kidney failure include increased morbidity, fatigue, malnutrition, sleep disturbances, poor sleep, poor physical functioning, physical inactivity, and poor quality of life. For my thesis, I will be concentrating on the sleep disturbances and physical inactivity in patients with kidney failure. Now, let's examine some evidence as to why physical activity and sleep are important in patients on hemodialysis. In this study, physical activity was measured in a group of in-center hemodialysis patients with an accelerometer, and after a 7-year follow-up period, they observed that participants with low physical activity had a higher risk of all-cause mortality. Another study looked at sleep quality using a questionnaire called the Pittsburgh Sleep Quality Index. In this questionnaire, a score of above 7 indicates poor sleep quality. Here we can see that poor sleep quality was associated with a higher risk of all-cause mortality. In addition to mortality, we know that being physically inactive and not sleeping well are associated with other negative outcomes in patients on hemodialysis. These include fatigue, lower lean body mass, depression, inflammation, poor physical functioning, and poor quality of life. Being physically active and sleeping well is crucial for the well-being of patients on hemodialysis. Thus, the aims of my thesis are as follows: to assess objectively measured physical activity and sleep and their temporal patterns, and to examine the effects of societal forces, the built environment, and the dialysis modality on physical activity and sleep. To study physical activity and sleep, it is important to have reliable measurements. Research-grade accelerometry is the standard for measuring physical activity, but due to its high cost, limited availability, and the need for specialized data analysis, it is not conducive to long-term monitoring. Wearable activity trackers, on the other hand, are relatively accurate, easy to use, and the data from them are easy to understand for the wearer. The gold standard for measuring sleep is polysomnography. Here on the right, we have a figure of a person undergoing a sleep test in a laboratory. You can see that he is hooked up to a plethora of sensors, and this is a very uncomfortable night of sleep. This method is also very expensive, limited in availability, and require intense data processing and interpretation by a sleep specialist. Wearable activity trackers are able to relatively accurately measure sleep, is comfortable to use, and lends itself to repeated measurements. Wearable activity trackers are conducive for the longitudinal monitoring of physical activity and sleep in patients on hemodialysis compared to other gold standard methods. In Chapter 2, we conducted a pilot study where we followed a small cohort of patients with a wearable activity tracker for 5 weeks. At the end of the study, we conducted a questionnaire to ask the patients about their own attitudes towards their physical activity and the activity tracker that they used. The majority of patients reported that they were able to incorporate this device into their daily activities, and about half wanted to continue using the device even after the follow-up period has concluded. Before we continue, I would like to expand on how hemodialysis is prescribed and delivered to patients. Like I mentioned previously, the most common schedule for outpatient hemodialysis is 3 times per week. So this is either done on Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. On any given day, a dialysis clinic will split their schedule into shifts. Here is an example of a clinic with 3 shifts, with the first one starting at 5 a.m. in the morning, lasting until 9 a.m., the second shift from 10 a.m. to 2 p.m., and the third shift from 3 to 7 p.m. Patients are assigned to their dialysis days and times and are required to attend all of their dialysis sessions during the date and time. Those who receive dialysis in the first shift may wake up at 3 or 4 a.m. just to make it onto their 5 a.m. dialysis treatment on time. In Chapter 3, we expanded on the pilot study of Chapter 2 by following a larger cohort of in-center dialysis patients for up to 1 year. We measured physical activity levels of patients as steps taken per day. The different colors on this histogram denote the tertiles of physical activity. We observed that the mean physical activity level was around 6,500 steps per day. We found that physical activity levels were highly varied, with some patients walking less than 1,000 steps a day, while others walked over 19,000 steps a day. We also found an interesting temporal pattern of physical activity. Here we have a box plot of the mean steps per day of patients on the Monday, Wednesday, Friday schedule and the Tuesday, Thursday, Saturday schedule, and we have Sundays in the blue box and the other days of the week in the red box. We can see that participants were least active on Sundays, irrespective of which HD schedule they were on. Next, I'm going to speak a bit about the built environment and how that affects physical activity. This is a picture of New York City, and this is a picture of Baton Rouge, Louisiana. It is apparent from these images that New York is more easily navigated on foot or via public transportation, while Baton Rouge is more car dependent. To study the effect of the built environment on physical activity levels, we used a metric called the walk score. The walk score conveys how walkable a neighborhood is or its walkability. It does this by taking into account multiple factors, such as how many amenities can be reached on foot, for example, restaurants, shops, or grocery stores, the availability of public parks, availability of public transportation, and other data parameters. We found that the walk score is correlated to physical activity. We also found that participants from New York City were more active compared to those from Baton Rouge. And lastly, we found that walkability is associated with different physical activity patterns. Now let's turn to how societal forces, such as government policies, may also affect physical activity. These are 2 pictures of Times Square in New York City before the COVID-19 pandemic on the left and during the COVID-19 pandemic on the right. To combat the spread of the novel coronavirus, the residents of New York City, like people all over the world in 2020, were asked to stay home. The COVID-19 pandemic afforded us an opportunity to examine the effects of strict lockdown measures on physical activity levels. Here, you can see the physical activity levels of dialysis patients in the 5 weeks prior to and the 14 weeks after the government-mandated lockdown. In week -6 here is the baseline physical activity levels before the COVID-19 pandemic was widely aware in the United States. We see that already in the week prior to the government-mandated lockdown, there was a marked decrease in physical activity levels compared to pre-COVID times. Moving on, I'm now going to discuss the other topic of my thesis, which is sleep. In Chapter 6, we conducted a prospective study where nocturnal sleep duration was measured with a wearable activity tracker in a cohort of dialysis patients for up to 1 year. We observed that participants slept around 4.5 hours per day on average. We found that the amount that our participants slept at night varied, with some sleeping just less than 2 hours a night, while others slept more than 8 hours a night on average. We also found several patterns of nocturnal sleep duration over time. Here we can see the sleep of participants on different weekdays. Participants slept almost half an hour more on Sundays compared to the other days of the week. When looking at dialysis start time, we found that patients who start dialysis prior to 8 a.m. slept on average 40 minutes less compared to those who started dialysis before 8 a.m. slept on average 40 minutes less compared to those who started dialysis after 8 a.m. We also saw that when we looked at the different days of the week as it relates to the dialysis treatments, that our patients slept almost an hour less on the night prior to dialysis compared to the night after the dialysis treatment and the night between 2 non-dialysis days. Finally, we wanted to know if sleep would be affected by different dialysis modalities. A randomized controlled trial was conducted where participants were randomized to hemodialysis or hemodiafiltration. Hemodiafiltration is another modality of dialysis where additional toxins and fluids are removed compared to hemodialysis. Patients were asked to record a sleep diary at baseline, 3 and 6 months after randomization. The average self-reported sleep duration was around 8.5 hours per night. Please note that this is markedly more than what we observed in Chapter 6, where sleep was measured with an objective method. We also saw that hemodiafiltration did not have any effect on self-reported sleep duration. In summary, long-term monitoring of physical activity and sleep is feasible in patients on in-center hemodialysis. Physical activity and nocturnal sleep duration varied widely in our patient cohort. We observed Sunday to be a day of rest where our patients were sleeping more and moving less. The dialysis schedule really disrupts the patient's sleep schedule, especially for patients receiving early dialysis prior to 8 a.m. Patterns of physical activity and sleep depend on hard and soft constraints of in-center dialysis, societal factors, and the built environment. Healthcare providers, caregivers, and patients should participate in joint decision-making based on evidence to improve physical activity and sleep. Monitoring with wearable activity trackers should be applied in specific subpopulations to measure the effects of interventions to improve physical activity and sleep. Wearable activity trackers may also be considered for the early detection of clinical decline for timely interventions. And finally, data from wearables can be used to create digital biomarkers to support the phenotyping of patients in the pursuit of personalized medicine. Thank you for your attention.
Thank you for your presentation. The opposition will be opened by Professor Rotmans, Professor Nephrology at the Leiden University Medical Center. Professor Rotmans was member of the assessment committee, and we appreciate your participation to this academic ceremony.
Thank you very much, Mr. Prorector, and thank you very much for your presentation and my compliments for your work and your thesis, which I really read with great pleasure. I'd like to include your promotional team as well, because it addresses two very important topics. I think, well, the quality of life of dialysis patients and the use of home monitoring for these patients, which is really important for the future as well. So thanks for that. But of course, I have some questions for you as well. And the first is more like a general remark or a question about the association between physical activity and health, right? Because I think in the general population, we try to promote physical activity for healthy persons because we think that on the long term that might improve their health conditions. And in your thesis, in your studies, you studied an already very severely ill cohort of patients, namely dialysis patients. So I was wondering, how in general do you look to the association between physical inactivity and the health of these patients in your cohort? Is that still a causal relation? And in which direction do you think the causality is there?
Yeah. Thank you, highly esteemed opponent, for your comments and your question. So you're correct that the population that I am studying, patients with kidney failure and on hemodialysis, are very sick patients. And they are often, like we found in our thesis and other papers in the literature, very inactive. We know that in this population that physical inactivity, very sedentary behavior, for example, patients walking less than 2,000 to 3,000 steps per day, is associated with a marked increase in the risk of mortality compared to those who are maybe not very active, but just adequately active.
Yeah,
say.
I'm going to interrupt you because
Okay.
I thought you were going to give that answer. But
Okay.
but do you indeed then think that if you promote activity, that would reduce their risk of adverse events, right? Or is it just a resultant of their poor health status that they don't move that much?
Yeah. So a lot of the studies in the literature are of an observational nature, mostly cross-sectional studies. So while we cannot necessarily infer causality based on the literature out there, we know that more active patients have a better chance of survival. Now, when we talk about improving physical activity in dialysis patients, I think it's also very important to think about their physical functioning or their capacity for physical activity. So more often than not, patients who are more active have a higher capacity for physical activity or better physical function. So it could be due to this that they have better likelihood of survival, and maybe the physical activity is just a symptom of their better health status.
Yeah. So you mentioned that, well, based on the literature and also in your own studies, that dialysis patients are not very active, right? But on the other hand, I noticed that the number of steps in your cohorts are quite high, right? Much higher than I expected. And though this could relate to the device, for instance, but I was wondering, could it also relate to your patient population of the cohort that you studied? So my question is, how representative is the cohort that you studied in chapter 2 and 3 for the total population of dialysis patients, in this case in New York City?
Yes. So the populations that we studied in chapters 2 and 3 were located in New York City, which is an urban environment.
Yeah.
So I would say that these patients are more active, or some of these patients, a subset of the patients, are more active than the typical dialysis patient. And I think this really is outlined in chapter 4, where we looked at the walkability. We also studied in that chapter patients in Baton Rouge, Louisiana, which is a suburban, very typical American town, right? And we saw that those patients were much less active than our cohort in New York City.
I understand, but I was mainly interested whether or not it was different from the dialysis patients in New York, because also the age, for instance, in your cohorts is about 53, right? And I'm pretty sure that the average age of dialysis patients in New York is much higher. BMI was 25. In the US, it's 29. Diabetes was far less frequent. So I got the impression that there might be some selection bias in your cohort as well.
Yes, I agree. So a limitation of my thesis is the selection bias of the patients. So our patients, as you mentioned, are younger than the typical dialysis patient, healthier, have less BMI. So this is definitely not generalizable to a typical dialysis patient.
Yeah, so for my last minute, I would like to ask you, how could you tackle that? Could you think of a scientific strategy to tackle this, actually, to have a better opportunity to assess the impact of dialysis on the physical activity of patients?
Yes, for sure. So I think in future studies, it will be very worthwhile to include a more representative population of dialysis patients. For the studies that we did in our thesis, we had resource constraints, right? And so we were only able to enroll the patients that we had access to. But I think it will be important in future work to include a more diverse population of dialysis patients.
Thank you. And well, my suggestion would also be to include a control group, right, for patients with similar age, for instance, that are not on dialysis, to actually see the impact of dialysis and renal failure. But thanks a lot for your question and for your answers, and I give the word back to the Prorector.
Thank you. The opposition will be continued by Professor Lins, Professor Comprehensive Atrial Fibrillation Management at this university. Professor Lins was also a member of the assessment committee.
Dear candidates, congratulations to this very nice thesis, not just to you, of course, but also to your family and also to your supervisor team, because actually writing such a thesis is always teamwork. And I think this is really reflected also in this very thick book what you actually have in front of you. I really enjoyed also reading it, and I also particularly actually enjoyed that you used wearables. Actually, it's considered more like a lifestyle tool, but now you also use it for patients. And I would actually like to focus there a little bit on the technology. Sleep trackers. So this was actually one thing what you used. You also showed in your presentation that actually the gold standard is polysomnography, overnight stay in a lab with a lot of sensors. So what do you think can those sleep trackers capture, and what do they miss when it comes to the tracking of sleep?
Thank you, highly esteemed opponent, for your comments and your question. So yes, polysomnography is the gold standard for measuring sleep. Now, the wearable devices on the market and also the wearable device that we used in our study claim to be able to measure sleep. And there have been validation studies done in the literature of the measurements by these wearable activity trackers against polysomnography as the gold standard. So what they found is that the device that we use, the Fitbit, is able to pretty accurately detect the sleep duration. So, for example, what time the patient went to bed and then what time they woke up. But in terms of the sleep quality metrics, such as sleep staging, this is still very limited. And we cannot say, for example, we can measure the sleep quality using these devices, but we can definitely measure sleep duration, and we can measure the relative changes of sleep duration over time.
Yeah. So what you mainly seem to track is actually sleep duration. So did you also see changes in the sleep pattern? And what I would like to refer to is, for example, if patients do not sleep during night, they might nap. So did you see different napping patterns in those patients, which actually might accumulate over time still to enough sleep?
Yeah. So in the studies that I conducted as part of my thesis, we only looked at nocturnal sleep. So we disregarded daytime sleep, and this is definitely a limitation of the findings of the study. The reason why we did this is because the device that we used automatically categorizes sleep. And so it does this based on obviously the accelerometry data, so the movement, but also the heart rate. And sometimes they misclassify very sedentary periods during the day as sleep. So to avoid this misclassification of potential sedentary time as daytime napping, we decided to not include daytime sleep in our analysis.
Yes.
But I agree that, for example, patients sleeping very little during the night may try to make that up with sleeping during the day, but this is something that we did not capture in our study.
Particularly also, I think, when a patient actually is on dialysis, this might be, be categorized as sleeping, right, by the tools? Maybe. So you also showed that Sundays, the patients are less active, and on dialysis days, they sleep less. So this was actually one of your main findings, I would say.
Yes.
Have you heard about the concept of fluid shift in patients with sleep disordered breathing? So this is actually something which is very broadly discussed in sleep medicine, also in heart failure, but also in dialysis. Have you heard about this?
Sorry, do you mind repeating that term?
The fluid shift.
The fluid shift.
Nocturnal fluid shift, yeah.
Yes, yes, I am aware. So that is associated with, for example, sleep apnea, obstructive sleep apnea. So this is very common in, like you said, heart failure patients, but also patients on hemodialysis because they are often fluid overloaded, especially, right before they go in for their dialysis.
Exactly.
Right?
In your thesis, you mainly blamed also the time point of dialysis to be responsible that the patients actually sleep less. Now, actually knowing again about the concept of fluid shift, so could it also just be that on the days when the patients actually get to dialysis, that they are just overloaded with fluid, and this might be a reason that they sleep less, or do you exclude this?
So the fluid overload, the fluid shift could play a role, I think. But in our study, when we looked at the different shifts, right? So we looked at the patients starting dialysis very early versus the patients who started dialysis later in the day. We found that patients who have dialysis later in the day don't have this very drastic change between dialysis and non-dialysis days. So while I believe that the fluid shift may play a role, the operational constraints, the scheduling constraints will also play a role.
Perfect. I think that's a good argument. You used the term walkable neighborhood. I understand this. So if you cannot walk, you will not walk. I would now introduce the concept of sleepable environment. So do you think that this might also play a role, at least in some patients? And if yes, did you look at this?
Yes, that's a very good point. So, of course, the environment plays a big role in how well one sleeps. For example, if you live in a very noisy city where there are lights on at all time of the night. New York City, for example, that would potentially disrupt your sleep. And this is a very interesting area to look into. Unfortunately, as for my thesis, we did not include this, but this is definitely something that I would be interested in studying in the future.
Yeah. So I think I still have 1 minute. Is this correct? So I would now also, well, of course, you can collect a lot. And the more wearables our patients wear, the more data is collected. But just collecting doesn't change anything, right? So given the results of your thesis, how do you consent now, or how do you inform, for example, also patients, or would you advise to inform patients in the future? Because this is actually used in a research environment, right? But actually a lot of the patients already have those wearable devices. So where do you think in 5-10 years we are at, and how would we implement this into the advice for our patients?
Yeah. So I think at least in the subset of patients who are not very active, there should be interventions deployed to improve physical activity in these patients. So I can see in the future that patients kind of bring their own device, right? So they have their own device, and then they can opt in to have that be fed into the EHR. And this data will not just come into the EHR as the raw data, because the clinician does not have time to sift through all of this data. It would actually come in as sort of a decision assistance tool for the physician and make recommendations based on the physical activity or sleep data from the patients. And then the physician can do with that recommendation what they like.
Yes.
Yeah.
Thank you very much.
Thank you.
And I would like to give the word back to the prorector.
Thank you. The opposition will be continued by Dr. Koster, Associate Professor in Lifestyle Epidemiology at this university. Dr. Koster was also member of the assessment committee.
Thank you. Dear candidate, also I would like to congratulate you with this good work, and I extend my wishes to your team as well. Your thesis really provides valuable insight in objectively measured physical activity and sleep, and I like how you monitor also these patients for a long period of time. I would like to start out with a question about the focus on step count, which I like because it's easy to understand, it's an easy measure, people understand it, policymakers understand it, but I can also see some drawbacks of the step metric. And I think of, for example, you don't look at sedentary behavior as a separate behavior, or you can distinguish the intensity of activity. How do you see that?
Yes, that is definitely a limitation of my thesis. So because of the tool we decided to select, which is the commercially available wearable activity tracker, wore on the wrist, the Fitbit device is what we used. This is not able to characterize, for example, sedentary time, posture, physical activity, intensity, like, for example, research-grade accelerometry can. So this is definitely a trade-off that we had to make. But like I mentioned in my presentation, this does lend itself, the wearable activity tracker lends itself to longitudinal measurement of physical activity, and it allows us to detect these patterns of physical activity over time. So I think when selecting the device that we used, we definitely had to make that decision.
But what do you think, also based maybe what is known about the literature and what you know about this particular patient group, is intensity important, or is it just any activity rather than the intensity matters?
Well, intensity is important. So the World Health Organization recommends 150 to 300 minutes of moderate to vigorous physical activity per week for an average adult. So it is important to characterize the intensity of activity, not just simply the steps per day. And actually, there are researchers who have worked to do that. So a study by Tudor Locke kind of did a systematic literature review where they looked at studies where physical activity was measured with accelerometer and with step count. They also looked at different laboratory studies where they had people on a treadmill, they know the intensity of activity and they measure the steps, and then they also looked at that in addition to just the basic level of physical activity it takes to function, to live. So they say that's somewhere between like 3,000 and 5,000 steps a day, and then adding on top of that the moderate to vigorous physical activity, which they say should be taken at a cadence of at least 100 steps per minute. So just heuristically, they say that the step count of someone who may fulfill the World Health Organization recommendation of 150 minutes of moderate to vigorous physical activity should be somewhere in between 8,000 to 11,000 steps per day. So it is a range, but I think we should definitely take into account the intensity of physical activity.
Yeah, thank you.
Well.
Yeah, maybe cadence is one option, to take cadence into account. Yeah, thank you. I would like to change topic and go to chapter 4. That's the chapter about walkability. You report here a positive correlation between walkability and physical activity. I see one drawback, that you don't take confounders into account. How can you be certain that this association is truly, that the association you find between walkability and physical activity is truly an effect of walkability,
Right.
and not another factor?
Right. Thank you for that question. So that is a fantastic point. So we did not take into account confounders in our study in chapter 4, partially because of the low number of patients we were able to include. But I agree that there are a number of confounders I can imagine that would affect physical activity, not just walkability.
Can you give a few examples?
Yes. So for example, socioeconomics, right? So this is very much so associated with where someone lives, right? Also, their background in terms of education, employment, right? This would, of course, have something to do with physical activity. And we also know that, for example, different neighborhoods may be food deserts. We have that in the US, where there's less access to healthy groceries, so the patient or the people who reside there are less healthy on average. So these are all potential confounders, which unfortunately we were not able to adjust for.
Yeah, thank you. And what I notice, if I go to chapter 4 and to table 4.1 on page 73, I see a big difference actually in BMI between those living or those having a low walkability versus a higher walkability, a BMI of 35 versus 28.
Yes.
So that difference in step count could very well be the result of that difference in BMI. So should we rather focus on people who are overweight and target these if we want to think about future intervention studies rather than walkability per se?
Yes, I agree. So I know that the BMI of the patients in Baton Rouge, Louisiana was a lot more than what we saw in the New York population, and this would potentially have an effect on physical activity levels. So if possible, I would like to repeat this analysis in a larger cohort of patients where we can be able to adjust for these confounders.
Thank you very much for your answers, and I hand over to the pro-rector.
The opposition will be continued by Dr. Wieringa. Dr. Wieringa is principal scientist at the IMEC and associate professor of medical technology at the Utrecht University Medical Center. Dr. Wieringa was also member of the assessment committee, and also for you, thank you for participation to this academic ceremony.
Okay, dear candidate, I was really impressed by reading your thesis. It's a nice piece of work, solid. But of course, it's our task to ask nasty questions. So one to start with is a minor one. We call this editorial when we have an IEC or ISO meeting. But it's nevertheless important in science too that the numbers add up. If we go to figure 6.1, my eye was caught by something that I could not explain, but I have a thesis about it. When I look upon the left chain, if we go down, we see that we have included 109 N, and 720 of this N completed the follow-up. That was strange to me. So when I counted the numbers and I saw that 72 was exactly fitting, somebody put an O there. We call this the printing devil. They always show up in the printery and they make these nasty adjustments. So this is just a minor thing, but I assume that the 72 was okay?
Yes, highly esteemed opponent, 72 is supposed to be the number of patients who completed the follow-up.
Don't worry, it's always a good test to see if they really read your thesis. So, like said, it's a fine piece of work. And the relationship between hemodialysis and nocturnal sleep is, of course, extremely important. But I have carefully read the whole thesis, and I only see in-center hemodialysis. And also only the 3 times 4 hour schedule. Now, of course, this is also, if you want to have high numbers and make conclusions, this is simply the most used schedule. Nevertheless, I was wondering, after your PhD, are you considering to carry on with this kind of research and maybe could include like home dialysis? What's the difference with home dialysis? Even if you have a 3 times 4 hour schedule, it would be interesting. So before, and also could be, of course, different schedules like frequent daily. That might be interesting. The summum of combining it all is nocturnal, of course. And there is nocturnal in-center hemodialysis and also nocturnal home dialysis. So that would be maybe very interesting as a follow-up, because I think that you showed in your slides that it can be, wearables can be applied on patients on in-center hemodialysis. I totally agree, but they can also be applied on patients on home dialysis. And my last question is, I'm an engineer and I also design medical equipment. So what is your dream wearable capable of monitoring? I'm not promising I can fulfill your wish, but
Okay. Thank you, highly esteemed opponent, for your comments and questions. So I will try to tackle them one at a time. So your first comment about other patient populations that could be of interest of using wearable activity trackers, I completely agree. So for the purposes of my thesis, we only concentrated on in-center hemodialysis patients, but it would be of interest for me in the future to study, for example, home hemodialysis patients, patients on frequent dialysis, so alternate day dialysis, and also nocturnal dialysis, for example. I would be interested very much to look at sleep in those patients. I agree. I think we should monitor these groups of patients, not just in-center patients. And then I think your second question was asking about my dream wearable. So I think especially in the population that we are studying, patients with kidney failure, it would be really, really great to have some assessment of blood pressure so we can do home blood pressure for the patients. It would also be great to have some kind of indication about fluid status, for example. And I think it would also be great if we can somehow be able to capture the patient's well-being, kind of how they feel about their general health, not just steps per day or how many minutes they slept at night.
okay. There is also now a tool which is FDA approved for atrium fibrillation, FibriCheck, and might also be an interesting one to use. And
Yes.
it's really available now in wearables. But those three, let's think about it because it makes sense to have these three. Thank you.
Thank you.
I give the word back to the prorector.
Thank you. The opposition will be continued by Dr. Christians, Associate Professor Nephrology at this university and at the Maastricht University Medical Center.
Thank you, Mr. Prorector. Dear candidate, I also like to express my congratulations to you and your supervisor team. And it's my task to have some questions about the thesis. A lot of the items are already discussed. But what I wonder is, you have the number with the Fitbit, the number of steps in the patient on hemodialysis, but I didn't saw how far are they different from the normal population in New York of Rouge-Beton. Do you have any idea about differences by the steps measured by the Fitbit?
Thank you, highly esteemed opponent, for your comments and your question. So while in our study we did not include healthy controls, this has been well described in the literature that generally speaking, dialysis patients are much less active compared to healthy controls.
You state it is well known, okay, but if I look at the number of steps, medium is about 6,000 steps a day. And if you look in Western Europe, I think about 50% of patients don't get those 6,000. So in that way, it's not different. Are the Americans different from the Europeans, or?
Yeah, so I think the cohort that we included was a highly selected cohort, as I mentioned before. So these are people who are younger and healthier than what is described as the typical dialysis patient. So I think it could be very much so the fact that these dialysis patients are more active than a normal dialysis patient, and these results may not be generalizable to every single dialysis patient.
Then one of the items always already some discussed is you have the number of steps. Well, it also go about exercise intensity. Mm-hmm. And it has been mentioned, you mentioned yourself, 150 minutes walk of activity, moderate, intense a week. And then it is, you have to increase your heart rate. And you said with the sleep part that also the heart rate was measured by the Fitbit. Am I right?
Yes, the Fitbit takes into account both the movement and also the heart rate of the wearer.
Why didn't you use also the heart rate and the intensity of the heart rate, or to change it in a day, than in your analysis, instead of only the number of steps.
Yeah. Thank you for the suggestion. So I agree that it would be very interesting to look at heart rate, but unfortunately for the constraints of my thesis, I only had the opportunity to look at physical activity and sleep. But I agree that it would be interesting, for example, to look at heart rate and how it relates to physical activity and how vigorous the physical activity is, for example.
Another part is that the 150 minutes a week walk, you cannot say it's 7 days, so 20 minutes a day will be sufficient. And even not if those 20 minutes are over a complete day, about 2 minutes walking each hour is sufficient. So do you have any idea about the variability of the exercise over the days or over the week in that patient? Because every day you have the moderate average, but how is that variability? That can also say something about the intensity that the patients move, because you have those number of steps.
Yes, I agree. So, of course, activity is a variable behavior. There is no one who does the same amount of minutes of physical activity, or I guess that's very unlikely that somebody would do exactly 30 minutes of physical activity a day. Something that is important to take into account when thinking about the physical activity recommendations is the bout of physical activity. So, for example, is it, just 5 minutes of walking broken up over the period of a day, or is it one consistent bout of 30 minutes of walking, for example? So we know from the data published from the UK Biobank studies that when they looked at the duration of physical activity bouts, people who tended to have these shorter bouts of activity, so not having a long continuous bout of activity, had a higher risk of mortality and other negative outcomes.
So in that way, you should do the move for at least 20 minutes or so.
Yes.
And you have those heart rates, so you might look in your data and look if there are any differences. If you add that give your data more scientific strength about it. Having said this, you use this Fitbit, yeah? And what kind of wearable would you like to use in your next study, if you have an unlimited amount of money?
Wow, that is a great question. So there are now, since we did these studies, which was mostly before 2020, there are a number of new wearables that are on the market. For example, I'm not sure if you're familiar with the Oura Ring, but this is a device that is able to measure not only physical activity and sleep, but also oxygen saturation as well. So it can actually detect apnea episodes during sleep. So I think this would be a great device when we're studying sleep, especially in dialysis patients, because we know that there is a high prevalence of sleep apnea in dialysis patients.
And how do you think about what Professor Lins said, atrial fibrillation? Because sudden heart death is an important cause of death in the dialysis
Yes,
part.
I think.
Can you detect that earlier? You said, okay, we might detect earlier disease of decrease in social health?
Yes, it would be interesting to look at AFib as well. So I think in order to make conclusive statements that we are able to have an early detection of these outcomes, we must gather first a lot of data, and I would very much like to do that in the future.
You already said there are new kind of devices. You have the golden stent, you told, but do we always have to test them to the golden stent? How do you compare them? Patients have their smartwatches or some other device, and you also have to standardize them and to compare them. How do you see that? What are your proposals for that? Because you want to improve the use of the wearables for your study, but also for the patients.
Yes, I think it's very important that when there is a new wearable on the market, that they are validated against gold standards, because we must first be able to trust that these are providing us with the reliable measurements. So I think, for example, the device that we used in my thesis, this has been well validated in measuring steps per day and also nocturnal sleep duration. So for whichever study you're designing, it's important that you are confident that the wearable device you're using has been validated against the gold standard.
You said it has been validated, but also the Fitbit, it has been validated that overestimates the number of steps.
Yes, so while the absolute values may be biased to overestimation, the Fitbit is able to measure the relative changes of steps over time, which I think is already providing us a lot of information, especially when we look at the patterns over time, or for example, if there's any marked change in these parameters before a clinical outcome.
Okay. Mr. Prorector, may I ask the last question? Okay. Somewhat different as the nephrologist, which I couldn't understand for the logical part. In, I think it was chapter 2, you also used the term equilibrated KT/V as a measurement of effectiveness of the dialysis. What's the equilibration you used in that definition? I couldn't find it in that way. What kind of item do you use to calculate it?
Yeah, so I believe we used the single pool KT/V, the Dalgertis equation for that.
Did you take into account the rest function of the kidney if the patient still wears on dialysis? Because that can also make quite a difference in the effective KT/V.
Sorry, I just want to make sure I understand. So you're talking about residual kidney function. Yeah, so in our population that we studied, none of the patients had any residual kidney function.
Okay, they were all anuric.
Yes.
And even then, you have patients who walk more and they have a lower AKT/V. That's contradictory, I would say. You dialysis more effectively, that's the way they say, to get them more in the normal way, active. But they have a lower one. And you give an explanation that they might have a larger volume of distribution. I'm correct?
Yes.
Yeah. And you say they have more muscle mass. If you look at the volume of the rheum distribution in a male of 80 kilograms, sorry. But how much liters do you have then as a volume of distribution?
So I think what you're referring to is the results from the univariate analysis where we looked at EKT/V as it relates to physical activity levels. So in that model, in the univariate model, we found that that was significant, but when we adjusted for other potential confounders, the significance.
Yeah, but the volume of distribution is about 40, 50 liter. How many kilos of muscle do you have to add to give that a significant improvement? According to me, it will be 1 or 2 kilograms, so it will only be 1 or 2% difference. And I can't imagine that that will be the reason why they have a lower AKT/V. There must be something different, but I wonder if you had any idea about it.
Yeah, so of course, KT/V is just one factor. I think physical activity is a very multifactorial behavior.
But your supervisor will say it is very important one in dialysis patients to give the effectively. But maybe, for time of sakes, I will give the word back.
The opposition will be continued by Professor Pierik, Professor Real-World Data for Chronic Disorders, in particular IPD, at the Maastricht University Medical Center. Professor Pierik is also the secretary of the degree committee.
Thank you. I first like to congratulate you a lot with this nice thesis and also your supervision team. It always makes me happy that we start to look a little bit beyond drugs and surgery and other interventions in chronic diseases. I would like to reflect a little bit about if it's really already useful to implement physical activity tracking in the clinic. And I would like to reflect on that from 4 aspects. First is the pathophysiology, and the second is the validation framework you used. The third is the technical possibilities to even do it. And finally, if we still have time, I would like to discuss a little bit about ethical aspects of sharing these data of patients with their doctors and their hospitals. But first question is, why are you measuring physical activity? What does it do? It's associated, of course, you discussed with previous opponents, with clinical outcomes. But what does it do in a body? If you have less steps, what happens? What is the underlying mechanism?
Yeah. Thank you, highly esteemed opponent, for your comments and your questions. So the first question about the role of physical activity in one's own health function. So physical activity, for example, stresses the heart, so it gives some cardiovascular benefits. So for example, we know...
Yeah, it does, but did you measure, or are there any papers in chronic kidney diseases that your physical fitness, you are referring, do you know what the 5 components of physical fitness are? So you have cardiovascular fitness, you have flexibility, you have muscle mass, you have body composition, and muscle resilience, I think. So what of these aspects, are any of these aspects decreased in patients with a lower physical activity in chronic kidney diseases?
Okay, thank you. So we know that from the literature looking at patients with chronic kidney diseases, that low physical activity is associated with poor physical functioning, frailty, muscle wasting. And we know that they also report that they feel like there is limitation due to the fact that they have this lower physical functioning. So it also affects the patient's quality of life as well.
Yeah, because in chronic inflammatory bowel diseases, we saw no relation between your activity level and your measured physical fitness, especially your cardiorespiratory fitness. Only in subgroups of patients. So maybe I think it's a good idea to look at what aspects of physical fitness are worse in patients moving less, to focus your training maybe on patients that are actually have less physical fitness measured with the test. But my second question is, you have all these wearables. Do you use a framework for validation before you implement them in the clinic?
Yes, so I think it's important, like I mentioned before, to validate these devices before we use them in the study. So when we were choosing devices to use in our study, we decided to use the Fitbit because at that time, this was validated in the healthy population. And they did mention in publications that they looked at chronically ill populations, not necessarily a hemodialysis population, but other chronically ill patients. So they did find that in those patients that there was some bias to overestimate steps, for example, but they were able to still measure relatively well the changes over time of steps.
And do you know the V3 Plus framework for sensor technologies?
No, I'm not familiar with that.
Because what they say, you did really nice studies and looked at if they measure what they measure, if people can use it. But I think before implementation to the clinic, what the other opponents also said, we still unfortunately need to show that it really improves the clinical outcomes. And then you validated the Fitbit, but I'm doing a trial with wearables myself, and all my patients have different wearables. And then I happen to be the Chief Science Information Officer working closely with medical information technology, and my opponent on the other side, he is like working with the MetaFib platform, and then I have the endocrinologist wanting to link all these glucometers to the... so how am I going to do that? Should I force all my patients to buy a Fitbit?
No, I don't think so. I think whatever this platform will be that we use needs to be device agnostic. So like I mentioned before, bring your own device, that it doesn't only work with the Fitbit or only work with the Apple Watch, but that patients should be able to use the device that they're comfortable wearing. Of course, it needs to be validated But that is kind of up to us as the researcher, but the patient should be able to bring their own device, and we should be able to then take data from different devices and be able to combine them. Now, this is a very ambitious task, and I don't think because of my thesis or the work that I've done that we are, in my experience, in my opinion, that we're ready for that yet, but we should take steps to be able to reach this goal and hopefully be able to help our patients.
And if you were patients, do you want to share your data with your doctor?
Yeah, so of course there are ethical concerns with these data being sent to different places to electronic health records. So I think we must consider very seriously data security, data safety, but also the patient feeling comfortable enough with what data they share.
Yeah, and also with the insurance companies.
Yes, definitely,
Yeah.
definitely.
Maggie Han, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and our return to this room. Maggie Han, the degree committee here present has assessed the quality of your thesis and your defense. In view of its positive verdict and taken into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Koolman is authorized to confirm upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
All rise, please.
Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent and responsible?
I promise.
So, by the authority vested in me by law and in conformity with the decision of the committee here present, I hereby confer upon you, Maggie Han, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, I now present you with the degree certificate signed by the rector, the secretary and the other members of the committee and affixed with the official seal of the university.
Well. I mean, I have the great honor to say a few words to honor you, Maggie, in a laudatio. And when I think about this, your story is a story of growth on so many levels. So just a little bit of background. We met in 2012 in an Italian restaurant. We're still debating actually what we had, but well, that's fine. We were introduced to each other by a friend of us from Austria. And I was immediately struck by Maggie's interest in medicine, in research. And so, because we just have started a study on wearable devices, I invited Maggie to join as an intern. And Maggie excelled from day one with her diligence, with her attention to detail, with her dedication. And she really moved this study on, and then she moved from step to step. And then an opportunity opened to participate in a randomized controlled trial, the HD FIT study that was done in Brazil, in Curitiba, where Maggie really advanced the analysis of this study. She wrote a paper about the study, and this really deepened her interest in the entire field. After that, we together, and with other colleagues, statisticians and so on, we designed this a large prospective observational study. To date, I think it's still the largest observational study done in dialysis patients using wearable devices. And it was really through Maggie, through her leadership and her organizational talent, her perseverance, her kindness, together with other colleagues, that the study was brought to an end in those testing times of COVID, which was was not an easy undertaking. And, I almost forgot to mention, in the meantime, as a sort of a side job, she was also executive assistant to me. And I mean, just to being executive assistant, when you work with an international collaborator network over 12, 14 time zones, organizing calls, organizing travel. I mean, this is not an easy undertaking, but it was very, very clear that Maggie is really up for additional advances. And that's why I'm saying Maggie's story is a story of growth. And Frank van der Sande and Jeroen Koman, we discussed, wouldn't Maggie be an ideal candidate for a PhD thesis? And thanks to Jeroen and Frank and other colleagues, you really managed to move forward, publishing good journals, and really eventually get to the point where we are now today. And I couldn't be happier about this. It has been a wonderful journey with you, Maggie. You really are such an inspiration also to others who are now aspiring to do a PhD, like looking at the Paranymphs here. And I think we really need these people who are, these colleagues who have a deep conviction that they can advance the field, that they really are an inspiration to other colleagues, and to have also success in the field that they're working. So I'm very curious what your next steps will be. Where will Maggie be in 5 years, in 10 years? I wouldn't be surprised if you're up to additional advanced positions. So I wish you all the best and congratulations. It's been a great honor working with you. Thank you.
Thank you.
Dear Dr. Han, also on behalf of the Board of Deans of Maastricht University, it's my pleasure to congratulate you with this new degree of doctor. It's already just formulated, in fact, by your supervisor. The expectations for the future are very high, and we hope that you will be very successful in your future academic career. Hereby, I will close this academic ceremony. Before congratulating the new doctor, the degree committee will take a picture with the new doctor and the family on the stairs in the central hall. Hereby, I close this academic ceremony.